also get some hot spots of the Botulli, which this patient doesn't have, which is also normal. Now, down in the feet, this probably does represent an arthropathy, but you find it very difficult to find, other than in a really young person, a bone scan where there wasn't some degree of arthropathy. So this is basically a normal whole body bone scan. The other point I point out to you is that the bone scan doesn't only show the bones, it also shows the kidneys. And I would advise in everyday life, any person looking at bone scans looks at the kidneys. Has the patient got 2 kidneys? Is there obvious hydronephrosis or whatever? As I said, this is normal. And the sacroiliac joints are normally of high intensity like that. And obviously that's the bladder. And again, continuing on about normal bone scans, although most of us would not like to admit it, there is usually a drop or 2 of urine in this region, and it causes quite a lot of confusion in the interpretation of bone scans. Now, yes, there you are, normal adult MDP, methylene phosphonate bone scan, MDP. Right. Now, this is also a normal bone scan, and as you can see, it's a child's bone scan, so you have all the epiphyseal activity. And that is, again, normal. And also in a child, you get increased activity at the anterior ends of the ribs. So, what does a bone scan show? Well, basically, it's not a simple story. Increased uptake goes with increased blood flow. So if you've got vascularity, as in cellulitis, for example, you'll get increased uptake. Also, it occurs with bone formation rather than bone destruction. So one of the problems you find is that if the patient has got just a purely, say, lytic metastasis, you won't get increased uptake. And photopenic lesions, which are now rather harder to see than hot lesions, are in fact quite often malignant. It's a very sensitive test, but it's also a non-specific test. And as with most nuclear medicine, you need to compare it with other kinds of imaging, plain films, or if you've got CT scans, MRI scans. So it identifies a problem, but you then need to look at the rest of the imaging quite often to help you work out what that problem actually is. Now, I don't know whether Dr. Khan's got me a candidate to ask me questions of.
Yeah, I'm there actually. Can you hear me?
Yes, I can. Are you Roland Musa? Yeah. Anyway, it is hopefully straightforward. You've got a 65-year-old male with back pain. Would you like to comment on this bone scan, please?
Yes, I've got anterior and posterior views of a whole body bone scan demonstrating multifocal increased uptake in the vertebrae and also bilateral ribs. There's some uptake in the pelvis as well. In a 65-year-old man, I'll be suspicious of sclerotic metastases, likely from a prostate primary.
Yes, I mean, that's right. I mean, it might be metastases from something else, but 65-year-old man, that is very likely. And likely things occur quite commonly. Okay, it's well done. Now, same person, and we'll also say that this person is a 65-year-old man. Would you like to comment on this?
Okay, so again, frontal and anterior and posterior projections. Again, this demonstrates diffuse uptake involving all the ribs, pretty much all the spine, bilateral symmetrical uptakes of the hemipelvises, with some uptake at the femoral regions as well. Again, I mean, in my differentials, I'll include significant metastases from a primary, or if there has been a recent radiation or a treatment, then that can sort of, if it's done in a very quick manner since the radiation therapy, then that can signify this off appearance as well. I don't really see any, but I don't see anything in the kidney. So this is actually in keeping with the super scan, which is different to what I saw previously. So again, metastases with the super scan and my forced differentials and other causes such as metabolic causes will be lower down my list.
Okay. Yes, I mean, radiation characteristically, at least after a while, produces decreased uptake. Often you get an area where there's a cut-off from radiation, it becomes very photopenic in a sort of a non-anatomical distribution with a sharp edge. So yes, this is right. The important thing here is that there are no kidneys. Now, as you can imagine, you know, the radiographers or nuclear medicine technicians produce the images, and if you were a nuclear medicine technician and you got this image, you would think, oh, well, maybe I've got the settings on my computer, on my monitor wrong. So you would, in fact, turn them down and get this. So that's, in a sense, one reason why at Basildon we do both the high intensity and the low intensity. Yeah, even with this, because there is no kidneys, you think, well, why are there no kidneys? Just as you did, and it's a super scan. Yeah, and it very often is metastatic, but it can be due to metabolic bone disease as well, as you said. And, you know, there we are. I'm on this topic, obviously. So that's prostatic carcinoma metastases. Now, and then so you look at this one, and this is also a super scan, but of course it's an easy super scan because there are still foci of increased uptake. And so, you know, it's obviously, or not, but it very much looks like metastases, whereas the previous one, you know, it's generalized. Now, this here, we're on to the ladies now, but same candidate. So this person here was on treatment for breast cancer, and they had these 3 methylene diphosphonate bone scans, and you see one is at time 0, one's at 4 months, and one at 6 months. And the oncologist went on giving the same treatment throughout these 6 months. Would you be able to explain what's happened?
So I've got 3 images at the start, 4 months and 6 months. So the first 2 images demonstrate a significant uptake in the vertebrae, multifocal uptakes in the ribs. Then there is some uptake in the skull region and bilaterally in the pelvises as well, which would be in keeping with likely sclerotic metastases from breast cancer. However, the middle 4 month demonstrates a bit more increased uptake, which would be, I mean, in the history that I provided, it might suggest a initial treatment response, which can be sort of overemphasized by more increased uptake. However, 6 months down the line, as the regions have resolved, I'm assuming that the patient has responded to treatment, and there is some photopenic areas now in the areas of increased uptake, suggesting a response to treatment.
Okay, so just to clarify, in between the first image and the second image, was the patient getting worse, having progressive disease, stable disease, or you think they were improving?
So if the patient was having treatment at that time, in the early phase of treatment, it's actually quite difficult to characterize if it's the disease which has progressed or if it's just response to immediate treatment. That's my understanding, but I could be wrong there.
Okay. So what would guide you in working out whether this was the disease getting better or worse?
I mean, in normal practice, I will correlate with plain films or any cross-sectional imaging that's available. I'm assuming patient will have sort of 3 monthly CT scans as well, so I could go by the bone density and the bone abnormality in the cross-sectional and plain film just to guide me as well in that circumstance.
That's right, yes. You couldn't really fully interpret this on its own, as you're saying. You'd need to have some other imaging as well. I mean, on its own, you might think vertigo that was progression. But I'll see what I've got here. Yeah, so it doesn't entirely help you, does it? But basically, what has happened, I think you were saying, was that the patient has lytic areas here, and then the patient had treatment and they became more sclerotic, and therefore they showed up on the bone scan where they weren't showing up on the first image. And then the treatment progressed, and then the areas of bone which went back to normal. In fact, you can see here there are on this CT image at the bottom, there's some lytic areas. And by the time we get to this 6 months image, they've become sclerotic. So although it might initially appear the patient was getting worse, in fact, this is healing of lytic areas with chemotherapy. Right. So it's a flare phenomenon. Right, okay. Now, without giving any information at all, what does this bone scan show?
So apart from uptake within the ribs, predominantly involving the whole of the sternum and multifocal regions in the pelvis, there is significant uptake actually within the ureters and the renal calyces, which are dilated, also signifying that there is bilateral hydroureteronephrosis, along with bony uptake, which would be, again, since I can see hydroureteronephrosis, I can be thinking along some metabolic causes, which involves the kidneys and things like hyperparathyroidism, or again, if there's a primary history, the skeletal uptake could be different to what I'm seeing on the renal uptake. There could be two different diagnoses going on at that point as well.
Yeah, I mean, does this image really suggest hyperparathyroidism?
Sorry?
You mentioned hyperparathyroidism.
Yeah.
Well, why do you think this might signify hyperparathyroidism?
I was just trying to see how the bony involvement and the kidney involvement can come together, and then that's the only logic behind it. I can't be completely wrong though. So.
So, in real life, and I'm afraid I don't think I've got anything to demonstrate real life to you, but in real life, when you saw this bone scan, what would you be asking for, or what would you be arranging for this patient?
I'll be arranging for an urgent start off with an ultrasound abdomen to look at the kidneys.
Yes, that's right. Because, I mean, really, this is just to show that on a bone scan, quite every now and again, not that unusually, people pick up problems with the renal tract. They pick up hydronephrosis, obstructive uropathy, which, obviously they should have done the renal function and should have known, but they didn't know. So this just is just to demonstrate that you see that, and then you have to be very careful in your report to mention this looks like an obstructive uropathy. I suggest, maybe an ultrasound of the abdomen. I'll obviously check renal function as well. Maybe not just hydronephrosis. Now, as you may know, the bone agents get taken up by all sorts of things, and breast cancer is one of them. Obviously, it's not. You can do CT mammography looking for malignancy with nuclear medicine, but it's usually a matter that somebody finds something incidentally in the breast when they're doing a bone scan. So it'll be taken up in a breast cancer. Okay, I'll just ask you about this one. What does this suggest in this short of breath patient?
So there is abnormal uptake involving the left hemithorax, which is diffusely demonstrating increased uptake compared to the right. I've not actually seen ever this in real life, but I assume that this could be an inflammatory process in the lungs, and there is a focal uptake actually within the ribs and in the posterior left mid-zone as well, which could suggest a focal carcinoma with some inflammatory changes elsewhere, but is definitely not normal, and I would correlate it with chest X-ray findings to evaluate this further.
Yes, and I think I actually might have got one of those. Yes, there we are. I've got a chest X-ray and a CT scan. So it might seem rather odd, but if you have a malignant pleural effusion, or for that matter, if you have malignant ascites, it's more likely to take up the bone agent. So this kind of situation, obviously you compare it with the CT, with the X-ray, but in actual fact it suggests a malignant effusion rather than say one due to infection or cardiac failure or liver disease or whatever. Right. Okay. I think I've changed person, haven't I?
No, I think I'm still here. I'm not sure. Yeah.
Okay.
So going by the same theme as you initially discussed, now this increased uptake in the soft tissue around in the abdomen, which is slightly distended, which might suggest a malignant ascites in this case because it's present in the upper quadrant, in the dependent portions in the pelvis, and in the paracardic gutters.
Absolutely correct. Yes, that's correct.
Excuse me, Andrew.
Yeah.
Time to go for candidate 2. So thank you, candidate 1. If candidate 2 can raise hand, please.
Okay. Now, would you like to comment on this and say what you, well, just comment on it.
Okay, so this is a AP and oblique bone scan of a 72-year-old male focused on the neck and skull. There is a rounded foci of increased uptake in the left supraorbital region. In clinical practice, I would correlate with a plain film. There is also increased density in the nasal sinuses, but I think that's could be within normal parameters.
Yes, I think the nasal sinuses is within normal parameters. We've also got a bit in the teeth, but you very frequently get a bit of dental disease. You also quite frequently get a bit in the thyroid gland, a bit of free pertechnetate going to the thyroid gland. So yes, I mean, other than identifying there was an abnormality, you'd have to correlate it with something else. Any idea what kind of things might cause something like that?
So a solitary kind of rounded lesion like that, potentially a plasmacytoma, or depending on the or a 72-year-old, so less likely to be in like kind of LCH-like lesion in a that would be more for a pediatric patient. But
Yeah.
or metastasis.
Yeah.
Or Paget, but I think it's more, Paget is more diffuse rather than a foci of like a circular foci when I've seen it, but it could be.
Yeah, I mean, Pagets would tend to involve a whole bone, wouldn't it? Or a whole skull, yeah. So probably not Pagets. You said plasmacytoma. Could it be that?
Well, we did say that. You did say that there's usually lucent lesions are usually osteopenic rather than hot.
That's right.
Yeah, but
yeah, so it's not likely to be a plasmacytoma. Okay.
So back to metastasis, maybe.
All right. Okay. I mean. Okay, anything other than metastasis? I mean, it might well be metastasis, but anything else? No. Okay.
You get hyperostosis with a meningioma.
Yes, you do. That is a good idea. It could well be that. And you get calcification with a meningioma quite often. And anything in the body that can produce calcification, even if only a weeny bit of calcification, can show up on a bone scan. Now, I'll just move ahead to find that. Yeah. Now, this is unusual. I wouldn't say you go around and you find these strokes like this, but infarcts in the brain, infarcts in the heart can produce increased uptake on a bone scan. Now, myself, I would have said, if I'd been seeing this on an everyday practice, I would have thought, oh, maybe this person's got a meningioma. But this wasn't. This was a stroke. Right, okay. Now, I think this is a different one that I can... Okay, I think I'll just... Now, this is... I won't ask you this, you've really said this already.
Yeah.
This is another whole body band scan. And as you can see, there's increased uptake in the skull. And we have there got a... Well, what does this CT head show?
This is a single axial slice of non-contrast enhanced CT head that shows an extra-axial lesion with calcification and localised vasogenic edema, but very minimal, and some sulcal effacement. I don't have it on bone windows, but I do get an impression that there is underlying hyperostosis in the left frontal bone. These features would, and alongside the bone scan of increased focus, increased uptake would be consistent with meningioma.
And what if we gave contrast? What would that show?
Homogeneous enhancement with a kind of dural tail.
Yes, I haven't got that, I don't think. Okay, it's meningioma. Right, so now the same doctor. This is, obviously it must be a man, mustn't it? It says PSA 75 query bone metastases. Any comments to make?
So I'm presented with anterior and posterior views, whole body views. There is a urinary catheter in situ, and increased foci superior to the bladder, which doesn't conform with any that is predominantly visible on the anterior view, and then more so on the kind of so on the more intense non-corrected view. I wonder whether this is it's exactly the same density as the bladder and is close to it. Wondered whether this could be a bladder diverticulum, but I can't get a connection.
Well, I think that's quite a good idea.
An oblique view could help. I can see that there's been extravasation at the injection site as well.
Okay, well that's fine. I think bladder diverticulum.
It's not widespread. It's not so with a raised PSA, and there's not evidence of kind of Just trying to see if I can see the kidney.
No, yes. I don't really think you can see the kidneys, but I think this is not the usual reason for not seeing the kidneys.
Okay.
So, it's not on this particular occasion a super scan. I'll go on because I think you've done very well, but also because it's... sorry, we did have some more views.
Okay.
You might not get any further with that. But I'll just go on and... Now, maybe you can work it out from that.
So the bladder is... is that a pelvic kidney?
That's right.
So pelvic kidney with a dilated pelvic ileal system.
Yes. I mean, as usual in radiology, you don't always get told the most basic things. So that was actually the clinical information, and of course we didn't really know what was going on. But yes, that density or area of intensity, if you like, down in the pelvis was shown on cross-sectional imaging to be a pelvic kidney. Pelvic kidney, yeah. Now, extraosseous activity on bone scans. Now, it is possible to get poor radiopharmaceutical preparation. and get the bone agent forming colloid and going to places like the liver and spleen. Certainly in nuclear medicine practice, if you get something that's very odd, one of the things to think about is has there been a problem with the radiopharmaceutical preparation? Is the same thing true in another patient done that same day? Just going down this list, renal failure, then you get generally increased background and sometimes increased uptake in some of the bones as well. And you can also get tissue calcification in renal failure, what we call it acute kidney injury, or chronic kidney injury. And so you get extra osseous activity. Spots of urine are almost universal, certainly in anybody over about 50. One or two little spots of urine are almost universal, and the patient doesn't actually have to have any obvious incontinence to get that. You know, tissue infarctions we saw, you may get some in the stomach and thyroid from a bit of free pertechnetate not bound to the MDP. Calcification anywhere, tumours, for example, in the breast. As we saw, pleural effusions and ascites, particularly if malignant. And hematomas, anything where you get a little bit of calcium, even microscopic, can show up on a bone scan. Now, okay, so I think I'm on the same person. So we've got a football player here with foot pain, and I've got those images, and those images. Right, okay, so sorry, I can't remember what my slide show. So I've got a football player with foot pain. I've got 3 sets of images.
Okay.
Would you like to comment on this football player?
Yeah. So I think this represents kind of a potentially a triple phase scan. So the first set is going to be looking at whether there's hyperemia in the area, of which at 5 seconds there's already an arrow has been very kindly put in the area where there is kind of increased foci of intensity, which would indicate hyperemia. And then I believe on the 20-minute scan there is a foci of increased intensity within this area and uptake above and beyond the background. And then furthermore on the really this is then delineated, clearly more delineated over the 3rd metatarsal of the right
yes.
Right foot, isn't it?
Yeah.
Yeah.
So what
So in a football player with football pain and with this distribution, I would be concerned about a stress fracture of the metatarsal.
absolutely, yeah.
So
And what do you call this kind of bone scan where you have different sets of images like this?
is it a triple phase? So you get a blood, you get a
That's right.
Yeah.
Or 3-phase, triple phase bone scan.
Yeah.
Blood flow, blood pool, and delayed bone phase images. And you are completely correct. It was a stress fracture. Obviously, you then get a plain film and so on. But as we all know, particularly early on, plain films may not show a fracture, particularly a stress fracture.
Okay.
So a fracture may remain positive for variable times, roughly 5 months to 2 years. So it's very difficult. You can't really sort of look at a fracture on a bone scan and say that fracture is, 2 weeks old, that fracture is, 6 months old. You can't do that. And skull fractures, if you think of a skull fracture and plain films, skull fractures often don't heal. So they don't always show increased activity on the bone scan. Right, okay, so this is not I won't ask you about it. So it's a jogger, got increased activity, and it was again a stress fracture. Okay. Now, this I will ask you about. This lady went jogging with her partner. It was the partner's. Oh, I'm sorry, that's hopeless. And you saw that, didn't you?
I didn't actually, but I wasn't quick enough.
No. Okay. So this is her friend,
Okay.
and this is the bone scan.
Okay.
Any comments on it?
So I've got anterior and lateral views of both tibia and knee joints on the anterior view. There is increased uptake in cortical uptake in the the right medial posterior cortex.
Yes.
Yeah, and less so inferiorly on the left as well. I wonder whether these represent shin splints.
Okay, and that's correct. So again, it's more obvious on the bone scan than it would be on the plain film, where you might get a bit of periosteal reaction.
Yeah.
So you get normal blood flow, normal blood pool, but you get this increased uptake posterior-medially where the soleus muscle inserts, and that's shin splints. And as I understand it, it's possible, at least to some extent, to continue exercising with this, with a stress fracture, you're supposed to rest. Okay, now another bone scan. Any comments on this?
Okay, so anterior and lateral views. There's increased uptake in 4 contigent ribs, as well as an increased foci in the right pedicle of a lower thoracic vertebra. And there is symmetrical renal uptake, but no kind of distension in the ureter and some delivery to the bladder. So I don't know whether that's actually more of a timing
Yes.
issue, rather not issue, but a timing rather than pathology. There's also another focus of intense uptake in the a high uptake in the right pedicle of the of cervical spine as well. Segment of it. It looks almost like it's at the end of the rib. So whether they've got a costochondritis, or is it not far enough anterior?
I think probably not far enough anterior, but more particularly, if you get uptake in contiguous ribs like that, it really is always due to trauma.
Okay.
And it doesn't have to be the most severe trauma. Very frequently on a bone scan, you'll find a rib with a hot spot. And when you've got a rib with a hot spot, even if the patient's got no malignancy, it's only about a 10% chance of it being a metastasis. It's much more likely to be due to minor local rib trauma. And when you get them in contiguous ribs, those are rib fractures. But, this patient doesn't need to have been run over by a bus. It could be may have fallen over. So it's the kind of thing where somebody can present with chest pain, and it might not be obvious they've got fractured ribs on a chest x-ray, but this shows that is in fact fractured ribs. Okay, so rib fractures. Oh, that's what I was saying. Single focus in ribs only metastatic in 10%, even if the patient's got a malignancy. And another thing is that if you have trauma, it tends to be a spot in a rib, Whereas if it sort of runs along the rib for a little bit, that might be more due to malignancy. Right, and so what's happened to this person?
They've been resuscitated. They've got
Yes, that's right, yes.
intensity in the sternum and bilateral rib fractures in the distribution, in which chest compressions would have put the maximal pressure and force against the rib.
Yes, that's right.
And they're lucky to be alive, so that was helpful clinical information.
Yeah. Yeah. Right. Yeah, cardiac massage. Right, okay. Now, this is somebody with edema and leg pain. And I hope I've got, yeah, there we are. This is not somebody who's just been running. Any ideas what this might be?
So, sorry, they've got generalised edema and leg pain, and they have got increased cortical uptake in the lateral aspect of both tibia and medial aspect of the femurs. Could this be... I would obviously in clinical practice correlate with any plain film to see if there was any kind of aggressive periosteal reaction, but the symmetry of it and the context of edema, could this be venous insufficiency or edema?
That's not a bad idea. It wasn't, but I mean, that is, you can get something similar with venous insufficiency. Probably it actually goes up a bit here into the femur. So anything else other than venous or arterial insufficiency, anything else might produce this?
I mean, the thing that I would be concerned about is HPOA. So have they got effusions and, have they got a symmetrical diffuse periosteal reaction secondary to...
Yes, that's right. I mean, yes, this was hypertrophic osteoarthropathy. And this is another example of it where it's in the arm. And you can see on the plain film there. Obviously, it's very often due to lung cancer or pulmonary problems, but there are other things, liver disease and inflammatory bowel disease and cyanotic heart disease. There are other things that can produce hypertrophic osteoarthropathy. That's what that is.
Okay, Andrew, we have to go to the next candidate now. Thank you, candidate 2. Candidate 3 is with us.
Thank you.
Hello. Hi.
Hello. I'll just move on. It's hypertrophic osteoarthropathy. Right. Okay. Now, obviously you've got a bone scan. Can you notice then that without me telling you about the patient, if I tell you too much about it, I'll tell you the patient did have a malignancy. Can you see any evidence of that?
So I've been presented with planar images of a bone scan, AP, frontal and posterior, AP and posterior. There appears to be a slightly increased uptake in the left upper zone of the thorax.
Right.
And there's been some this patient has a malignancy, you're saying.
Yeah, the patient's had a malignancy, yeah.
So I wonder if the patient has got a left upper lobe mass.
That's not what we're looking at. I mean, the patient might have had an upper chest mass. What I'm really looking at is the result of some treatment of malignancy. Can you see what treatment has this person had?
So, I mean, I'm seeing increased uptake within the kidneys bilaterally and also along the iliac crest. I'm not
Okay.
sure where exactly the tear may have been, actually.
Okay, I'll point it out that what we're really looking in this case anyway, is decreased uptake. This patient's had radiotherapy, so you go up their spine and then there's an abrupt sort of non-anatomical cut-off there with very little uptake here. Obviously, you want to look at plain films and know more about the patient and so on, but this was really just to demonstrate that this abrupt end of uptake is what you would see with radiotherapy.
Okay.
Oh yes, it was left apical lung mass, but it's not the left apical lung mass you're actually seeing there. That's the radiotherapy. That's probably, I don't quite know what that is. That you pointed that out, didn't you? Right. Okay. So, a 40-year-old man with foot pain and swelling, and got that. Yes, sorry. I've got these 3 sets of pictures. What can you tell me about them?
Yeah, so these are several images of a bone scan. This initial image is the initial blood flow, which shows what I think is normal uptake on the right side, but reduced rate of uptake on the left. And the blood pool image subsequently, the uptake has increased, but the distal aspect, the toes of the foot, have not taken up any any of the LDP yet, technetium LDP yet. And in the subsequent image, there's no uptake either.
Looking at these images, obviously you had the patient there when you'd asked the patient a question, but which side, looking at these sets of images, is the abnormal side?
I think on this image, I mean, one side obviously has a much more significant uptake compared to the other, so I think it's the right side which is abnormal.
Right, okay. And what kind of problem might this person have got?
So it will be due to hyperemia. So the patient may have a focal infection or osteomyelitis, which is causing the increased uptake of increased amount of blood going to that area, and therefore causing the increased uptake on that side.
Yes, and again, what kind of bone scan is this where you get the 3 sets of images?
So it is a triple phase.
Yes, that's right. Blood flow, blood pool, and delayed bone phase images. So yes, it may be an infection, mightn't it? It's osteomyelitis. I think that's quite possible. From where this is, would you like to sort of classify it in a slightly different way? Osteomyelitis is fine, but where is it?
So it's in one of the toes, probably the third toe, the middle and distal phalanx, probably of the toe.
Yeah, it's on either side of the joint, isn't it?
Sorry.
Yeah, I mean it might involve osteomyelitis of, say, the metatarsal and the proximal phalanx, but obviously I think the joint in the middle would also be involved. Yeah, but and here we have the plain film. Yes, and as you said, osteomyelitis. I think I would say it could also be a septic arthritis because it's around the joint, but yes, that's fine.
Yeah.
It's not very easy to tell cellulitis from osteomyelitis on these scans, but, well, firstly, because blood flow is increased, and therefore in cellulitis you do get increased uptake in the area affected by the cellulitis. But on the whole, it tends to be much more diffuse. you get persistent soft tissue uptake with an osteomyelitis. It tends to, in the delayed bone phase images, tends to disappear from the soft tissue, at least to a considerable extent, and have more focal increase in the skeleton. So to some extent, it's possible to tell a cellulitis from an osteomyelitis.
Okay.
Right, I think I will just go through this one. 30-year-old man bitten by a dog. So that's a blood flow. Sorry, it's not. It's a blood pool image. It's a 5-minute image, a blood pool image. So I haven't shown you the blood flow images. That's a blood pool image. Mm-hmm. And that's the delayed bone phase image done at 2 or 3 hours. And this is on either side of the joint, and that is a septic arthritis. Okay, now this person, 67-year-old man, pain on mobilizing. Would you like to make any comment on this bone scan?
Yep, so this is a plain bone scan, frontal and posterior views. I can't see the kidneys, so this is a super scan, and there is asymmetrical intense uptake on the patient's left femur and the pelvis as well. The SI joints are quite significantly picking up the tracer also. There's also increased uptake in the spine, which is fairly homogeneous, and the left sternoclavicular joint is probably as well high uptake as well. I see some increased uptake in the joints in the left ankle and less so in the right ankle. So this is in a 67-year-old male patient who's got pain on one side. Just to look at the femur itself, there are areas of photopenia in some parts of the bone, and given that it's actually on just one side, and it's got areas of photopenia, I wonder if this is an element of Paget's, given that the skull is also significantly taking up the tracer.
Yes, so that's right. So again, we compare it with the plain films, but this is uptake throughout the left femur and pelvis and the skull. If you remember, Paget's feature of it tends to involve a bone from one end progressing to the other, and very frequently, particularly if it's a small bone, it involves a whole bone. So that is a different distribution to, say, metastases. So this would strongly suggest Paget's disease. And that is what it was. There is a Pagetic pelvis.
Yep.
Thickening of the cortices and coarsening of the trabecular pattern and bony expansion. And this one here, it's in the knee progressing up the bone. Again, that, although you can't be certain what it is, that very much would suggest Paget's disease. And it was Paget's disease. And I think there was a bit in the skull as well. I can't really see that properly, but there was some in the skull as well. It doesn't necessarily follow that all Paget's have increased uptake on a bone scan. Paget's can become burnt out, and that's just an example of a very Pagetic calcaneum. That wouldn't necessarily show up on your bone scan, or you might get secondary degenerative change in adjacent joints. Okay, so same person. What about Father Christmas? What's he got wrong with him?
Yeah, so similar planar images again of a bone scan. There's intense uptake in the mandibles bilaterally. And I can see the kidneys, so it's not a super scan. I don't see any significant abnormal uptake elsewhere. So this could be a patient who's got what do you call enlargement of the mandible. So this can happen with acromegaly. Possibly with Paget's as well, but I was thinking of acromegaly initially.
Yeah, I don't know myself whether acromegaly would just involve the mandible and nothing else. And it was there it is in a lateral, and it was in fact Paget's disease, which I think really is what it looks like. I think acromegaly would involve the skull as well. Now, what about this one? This is obviously not very easy to comment on, being just a bone scan, but there we are. Any thoughts on this?
So these are planar views of a bone scan again. There is bilateral high uptake in all the appendicular skeleton. I don't think it follows any symmetry bilaterally. It's a bit more prominent on the left side than on the right. And the joints where I would expect degenerative changes to be present are showing high uptake as well. And the skull base also. I would compare this with previous radiographs. But is this I don't think this is a child, but
no.
It's previous trauma to various parts of the body may cause this possibly. But I think the high uptake is mostly within the medulla rather than cortical, so I don't think they're all fractures.
It would have to be very expensive, wouldn't it? If it was trauma, this person would have to have been run over by the bus.
Yep.
Yeah. So, it wasn't trauma. Anything else it could be?
Well, it could be a metabolic disease, something of course systemic. Could it be inflammatory arthritis possibly?
Arthritis involves joints, doesn't it? And this involves the middle of the bones as well. So I don't really think it could be an arthritis. I don't think you could really work out what this was just from the bone scan. But no, I don't think it can be trauma. I don't think it can be an arthritis. I think I better show something else. Now, this is a related radiograph. So what is it then?
So these are AP views of the lower limb in a patient, and the most apparent the abnormality I can see is undulating expansion of the fibular shaft on the left side, and the cortical thickness is very irregular throughout the fibula as well. I wonder if this is malarial osteosis possibly, or
possibility. So I'm not a real expert on malarial osteosis, but I think that's a possibility. It wasn't actually, but I think that's a possibility. You get sort of candle wax with that, don't you? Yeah, so other than malarial osteosis, another not uncommon condition that can be hot on a bone scan.
Not uncommon.
Not that uncommon. It's not moderate.
I am not sure.
No, okay. Right, well, this sort of ground glass area is bits of expansion.
So this is fibrous dysplasia.
Yeah, it's fibrous dysplasia, that's right. And that, I mean, you can't really look at that image and say, well, that's fibrous dysplasia. But you could look at it and say, well, it's not Paget, it doesn't really look like METs extending along the areas of the bone like that. It could be METs, but not so likely. It's not an arthritis, it's something in the bone, multiple bones. And that, this shows you that it's fibrous dysplasia as we've got here as well. And the skull base, we get increased density. I think Dr. Khan's just appeared on the picture.
And this is break time now, 5 minutes break. And after the break, thank you, candidate 3 and candidate 4 will be with us after the break. 5 minutes break now.
this is another example, a 25-year-old with great increased uptake in left arm, and there's a plain film showing fibrous dysplasia. So when you think about comparison of Paget's disease and fibrous dysplasia, I mean, it can be difficult. Of course, Paget's disease, on the whole, tends to involve older people, will involve a whole bone, whereas fibrous dysplasia may involve several bones quite often, but it doesn't have to start at one end and progress to the other. It doesn't have to involve the whole bone. Right. And again, we've got a bone scan here. It's increased uptake in a rib. Obviously, you want cross-sectional imaging or chest X-ray. This does seem to run along the length of a rib. There we are. So it's not likely to be trauma. That's the lateral view. And that, again, need the cross-sectional imaging to identify it as fibrous dysplasia. So, as we probably mostly all know, bone scan is very sensitive, it's non-specific. You need to compare it with the other imaging. If an image, there are quite a lot of benign bone diseases which have increased uptake, such as, if you've seen, Paget's disease, fibrous dysplasia, giant cell tumours, aneurysmal bone cysts, quite often enchondromas. So you can't look at something and say, oh, this is taking up MDP, therefore it must be something nasty. Also, you see osteoid osteoma, chondroblastoma. There's quite a lot of things which are typically hot, but a bone island is not hot. So if you see a little area of sclerosis in the bone and you do a bone scan and it's not hot, that's very a good indication that's it's a bone island. So most malignant bone lesions have increased blood flow, and most benign bone lesions have normal blood flow. But again, there are some exceptions. As we've already seen, some fractures, stress fractures, may have increased uptake on all three phases. Osteoid osteoma has increased uptake on blood flow, blood pool, and the delayed bone phase images. As does complex regional pain syndrome. It may be hot on all three phases. So, here we have blood flow, blood pool, and delayed bone phase images. Clearly this is a child because we've got increased uptake in the epiphyses. And we here have the CT scan. We've got sclerosis, loosened area and a little area of density in the middle. As you probably realise, that's an osteoid osteoma. But at least the bone scan has identified where the problem is. Right. Sorry, hello?
Yeah, I'm here.
Are you my fourth candidate today?
Yes, I am.
Sorry. Okay, so we've got this. Now, if you were to find this in your plain film reporting pile, what would you say about it?
So I think this is on the frontal radiograph of this right shoulder. I can see there is a lesion in the proximal right humerus, which has got a ring and arcs configuration of calcification, has no surrounding periosteal reaction, no soft tissue mass. It has a narrow zone of transition. So my most likely diagnosis would be an enchondroma.
Right. Now, what about if it was painful?
So if it was painful, well, I could consider other things, because it doesn't look like it's got any aggressive features. So painful lesions could be osteoid, osteoma. This isn't a classic location and doesn't look like an osteoid, osteoma. In children, Ewing's and things like osteo, but this doesn't look like a child could be painful as well. Other than that, it could be a hemangioma as well, because that could be.
Right. So that was the bone scan.
So it does show uptake on the bone scan. There are no other areas of abnormal uptake elsewhere, and I can see the renal outlines as well. So she's got a 6-month history, and I'm thinking it doesn't look like something malignant to me. It's something benign, but sure, it probably has an osteoid matrix, hence it's got uptake in the bone scan.
Is it safe to say that's benign?
I mean, not entirely. I'd have to look at CT and I'd have to correlate with the other images, and but just looking on the X-ray alone and then looking that there's no other areas of abnormal uptake, and I can see the renal shadows, which obviously does not always mean there's no malignancy.
Yeah. Okay. Well, I'll hurry on a bit because I've been told we need to hurry on a bit. But basically, we thought this was benign, but we were wrong. And I think the point is the patient had, really definite pain there. And in fact, that's what it turned out to be. And we looked back at, I haven't got it to show you, previous images, which happened to be seen, I think it was on a chest x-ray. And in fact, there was an area here that was becoming destroyed. This area of some matrix calcification was extending down here and it being destroyed, and it was in fact found out later a chondrosarcoma. So I just think you need to be very careful with people with pain. To say it's a benign. I think somebody here thought it was an infarct, but it wasn't. Okay, now this is. You get generally increased uptake in the tissues, and you get increased uptake at the ends of the ribs. I think this will turn out to be, look in a minute, renal failure. This is, obviously not something you diagnose or chronic kidney injury. You don't diagnose it from a bone scan, but on a bone scan you'll see increased uptake in the soft tissues and at the anterior ends of the ribs. Yes, renal osteodystrophy. Okay, and this, we had super scans due to metastatic bone disease. You can also get super scans due to metabolic bone disease, and that also includes renal osteodystrophy. So these are the features of renal osteodystrophy. Increased uptake of costochondral junctions, fractures, brown tumours, and possibly increased uptake also due to calcification in the lungs and the stomach. I will ask you some more questions in a minute. I'm hurrying partly because of time, but also because this is not a very common sort of diagnosis to make. 18-year-old male, where you have increased size of the kidneys, you often get calcification in the spleen, increased uptake at the ends of the bones. It's sickle cell disease, but obviously you don't diagnose sickle cell disease in this way. Periarticular uptake, skeletal uptake, calvareal uptake, and you may get photopenic defects, which are due to bone infarcts, which later heal, and then you get increased uptake at that area. Now, this section is about MSK, and whereas this is mostly about bone scans, this is just an example of an HMPAO labelled white cell scan, which again fits with this area of a diabetic foot, where there's been an amputation. And of course, there may still be some infection in that region. Now, somebody who's had previous trauma, particularly severe trauma, may present like this. Would you have any idea what this might be? It's not a very common thing.
I'm thinking so they've got uptake in both shoulder joints and both hip joints, and then along the medial margins of the distal femurs. And they've had difficulty mobilizing. I'm thinking whether this would be a reflex sympathetic dystrophy. Or...
I think that's quite a good idea. It's in quite a few different areas. I think that's probably, then you tend to get increased uptake, blood flow, blood pool, delayed bone phase images. But this wasn't that. This was as it happened. So anywhere where you can get calcification,
okay,
you get increased uptake. I mean, I'm not saying you should have got that. I'm just saying so. Now, any idea about what this is?
So on the anterior projection, I can see there is a well-defined photopenic area, which I cannot see on the posterior view. So two things. I'm thinking whether this is an artifact. It's very well defined, and I can only see it on the anterior view.
Okay. Well, let's say that's a good idea, being an artifact. And quite often you get coins or things in people's pockets or pacemakers. So this person had a breast cancer in the past. So what might that artifact be?
This could be, and then in that context, this is a breast implant, which would be photopenic as well.
Now, cold lesions on the bones, I'm not sure. So I've got something popping up. Cold lesions on the bone scan can be quite a problem. They're much harder to see. Obviously, said objects in the pockets and so on. Photomultiplier tube failure, which will tend to produce a sort of circular defect. Radiotherapies we had earlier on. Bone cysts. But malignancies, where you get a lytic area like renal, thyroid, these may also show as cold lesions. Yeah, so these are the cold lesions on a bone scan. Let's see if I move that out of the way. Now, I need to rush on a little bit, but this is a 66-year-old lady with hip and back pain. This is quite a common thing we find. And I'll just tell you what this is because of lack of time. But basically, we've got increased uptake in the sacrum. You always get a bit of increased uptake in the sacrum, but
Sign.
Absolutely, yeah. So there it is, obviously in the MRI, but it's often initially shows up, in fact, on a bone scan. Now, could you just tell me why this person is not walking around very well?
So they've got arthritis in the knee joints.
Yes.
And in the shoulder joints as well, but predominantly the knee joints. We've lost the disc space, we've lost the joint spaces, so in the weight-bearing joints. So
What about this bit here?
And then there is a linear uptake in the lumbar vertebral body. So it's linear, but it's not like a focal at the site of the pedicle.
So that's right. So this basically, as you're saying, this is the appearance of degenerative change. I mean, this is like most of our bone scans, really. So we've got increased uptake at the first carpal metacarpal joint. But these linear areas in the spine, as you say here with these modic changes, the fact that linear is linear does strongly suggest it is, degenerative. Just OA, basically. Now, just to show this, we've got pain post-injury, or it might be post with a neurological abnormality, or or an MI. You've got increased blood flow, increased blood pool, and increased on the delayed bone phase images.
So
And
I
that-
think this
Go on, yeah.
reflects sympathetic dystrophy.
That's right, yeah.
Yeah.
Otherwise, I think these days there's complex regional pain syndrome. I don't think people fully understand, exactly, I don't understand what it is really, but basically you get increased vascularity, vasomotor instability, and this increased uptake on all three phases.
Yes.
Sometimes, though, perfusion is not increased for some reason. And you get osteoporosis classically on the plain films, but that, it's very difficult to see osteoporosis on a plain film. And just finishing off the bone section here, this is a renal transplant patient who is having difficulty mobilizing. And what do you think is wrong with that?
So I can see there is increased uptake in the right hip joint, and then there's what appears to be in the region of the bladder as well. And I'm thinking whether this is a renal transplant patient. They've been on steroids and they've got AVN on the right hip. It's almost like a double sign that we see. And it's
That's right.
Yeah.
That's what it was. And there's the renal transplant there.
Yeah.
Yeah.
Excuse me, can we now go to the next candidate? Thank you, candidate 4.
You're welcome.
And the next candidate will be candidate 5, please.
Yeah. I'm sorry, folks, for hurrying. Now, we're now on to kidneys. Okay, so I've got a couple of pictures here. Now, could you just tell me, I've projected it, could you tell me what you've got here on this screen?
Hi, is this a MAG3?
Yeah, quite likely.
And
So which part of the examination is this?
so you can see there's a graph at the bottom, and there's increased uptake in the beginning, and then after about 20 seconds, it appears to plateau off.
Yeah, is this normal or abnormal?
It looks abnormal because there's
Looks
no
what?
decrease. Abnormal?
I think this is basically a normal one.
Okay.
Okay. So which part of the examination is this? Is this the whole examination or?
I think it's the beginning. I can't see an excretory phase.
Yeah. So if you do a MAG3 or, as we used to do, say a DTPA renogram as well, the examination has a perfusion phase and then a concentration and excretion phase. So this is in seconds. So obviously this is perfusion. This is not the whole examination. And here we've got the scintigram images at the top showing it, the activity coming down the aorta, going to the kidneys and so on. So this is just the perfusion phase, and that's the curve for the aorta, left kidney and right kidney, and that's basically normal. And it's the blood flow analysis part of the examination. And so what part of the examination is this?
The excretory phase.
Yeah. So all examinations have these two different parts. And is this normal?
It looks normal, yeah.
Yeah. Okay. Which kidney is this one?
I think this is the left kidney.
Yeah. Yeah. Now, I mean, admittedly, you might have sort of left and right marked on something, but when you're doing kidneys, because they lie posteriorly, you'll have the gamma camera behind the person. So unlike most radiology, where the left is on the right side, in a MAG3 renogram, usually the left is actually on the left side. Okay, so yeah, that will be the left kidney, quite right. And we've got the ureters, these are the scintigram images and going down into the bladder. Right. And you get the scintigram images and you also get the curves. And this is the curve of a renogram. And basically it's a normal examination. Okay. So this is just really what I've said. Nowadays, you tend to do MAG3 because it's actively secreted, whereas DTPA is just filtered. So very often you just look at the sort of shape of the curves and so on, but really, time to peak activity should be 3 to 5 minutes. And something people do look at is the time for half of the activity to go, which is 8 to 12 minutes from peak to half peak. So if you've got obstruction, that will be prolonged. And also the 20-minute to peak count ratio, which for MAG3, because it's actually actively secreted, should be less than 30% at 20 minutes. So what's this? What's this person got?
A horseshoe kidney.
Absolutely correct. There you are. So horseshoe kidney. Now, unlike many kinds of imaging, you can imagine you've got an anterior view and a posterior view. And the posterior view, you see, there's not so much in the middle because you have the spine in the middle there. So, the gamma waves don't go through the spine. There's more there on the anterior view because the isthmus, of the horseshoe kidney may be very thin, but that's the area of activity there in front of the spine. So anterior, you'll see it. And sometimes you get a bit of biliary excretion. So that's what that is in the gallbladder. Okay, so what's this?
A transplant kidney?
Transplant kidney, okay. So it's a transplant kidney in the right side or on the left side?
So it will be on the left side.
No, I'm confused. I produced the answer myself. So basically, the situation here is if you're thinking to transplant, it goes in the front of the patient. So unlike, normally with a MAG3, you put the camera behind them. I'm sorry about this. I've purposely misled you in the sense for the transplant, you put the camera in front. So that would be the right kidney. And this is the perfusion phase of a transplant renogram. And there we have the iliac artery and the transplant, and it's perfusing well. And in fact, that's the scintigram images, and they look very good. Yeah. So in fact, we said normal half time was 8 to 12 minutes, which is 13 minutes, which is really not very bad, not bad at all for a transplant. Patient with a single kidney, it's working quite well. Now, this person, it says they have hydronephrosis, so they probably found they had hydronephrosis from an ultrasound. So what have we got here?
So you've got, so this is a MAG3 study, and you have uptake of the tracer in both kidneys.
Yeah.
And in the left kidney, it plateaus off at approximately 25 seconds, but in the right kidney, it continues to increase.
Yeah.
I
So
can't see any.
Right. Which kidney is
I can't
likely to
see-
be nephrotic?
So it's most likely to be the right kidney.
No. If you have a hydronephrosis, say due to some kind of obstruction, you also get decreased perfusion. It might seem so. This is in seconds. I know that if you have a hydronephrotic kidney, if you look at it so in terms of minutes, you'll get build up in the kidney, won't you? As we'll see in a minute. But when you have the perfusion phase, which this is, the obstruction produces a decreased, a lower curve, decreased perfusion. Now, later on, so this is the perfusion phase. Later on, when you come to the concentration and excretion phases, which might be why you were thinking what you were thinking, then in this case, the one that's blocked up gradually increases. The curve just goes on and doesn't fall. Now, this curve itself for the other kidney is not completely normal, but what usually happens is you usually give a diuretic at about 20 minutes and then it falls. So this just shows that the right kidney in this person had a rather dilated, sort of rather baggy, probably an extrarenal pelvis, but one that's not anatomically obstructed because the curve falls. And there we have the left kidney, which was the one that had the poor perfusion and was obstructed. So I said the right one was dilated and non-obstructed, the left one was dilated and obstructed. Now, I won't ask you about this, but just to say you've got these curves, we haven't got the normal nice up and down curve of a completely normal renogram. This is again at a plateau on both right and left kidneys with a rapid fall after diuretic. So again shows these baggy bilateral baggy pelvic heliceal systems. Now, I will ask you about this one. It's a 53-year-old male with loin pain. Could you tell me which side is the loin pain?
Left side.
Yeah, and by left side, do you mean this one?
That's right.
You mean that one, yeah? Okay.
Yeah.
And why do you say that one?
I can't see any uptake of the tracer in the left kidney, but I can see it on the right in the right kidney.
Yeah.
And I think in the delayed images there's some cortical uptake.
Yeah,
So it looks like
we used to see years ago in our IVUs, we've got a delayed build-up in the cortex of the kidney. So this kidney, the left one, is likely to be obstructed, gradually builds up, and the right one, you can see activity in the pelvic heliceal system, you also see activity in the ureter. So yes, you're quite right, it's likely to be left loin pain due to a left-sided obstruction. And it's obviously a very old slide, isn't it? But you see the left side gradually builds up, whereas the right side has a normal curve. So an obstructed left kidney, and this patient, not here, but did have a repair. And after their repair, after their surgery, the drainage from the left kidney dramatically improved. So it wasn't completely normal, but you see it's now falling away as it normally should. And you get you get radioisotope in both ureters. Now this person, right hydronephrosis, and they have the diuretic injection, and the left side's fallen very nicely. The right side falls a bit, but doesn't really fall normally. It doesn't come down here, it drops a little bit. So it's partial obstruction, because these things are not a matter of completely obstructed or completely patent. So this person does have a problem. They've got a partial obstruction to their right kidney. You see here the hydronephrosis. Just to say that to make renograms work, the patient must be well hydrated, the bladder mustn't be over full. Okay? And if the patient has very poor renal function, you will not get a response to diuretic. And that can lead to a misdiagnosis or obstruction, as we might see in a minute. So this person here had a cardiac arrest, and they had renal failure after their cardiac arrest. Would you like to put a name to what this might be?
Could it be acute tubular necrosis of the kidneys?
Yes, that's correct. So basically, it's concentrating the kidneys, but it's just not being excreted. And I understand that if you get concentration like this, it's quite a good prognostic factor, in the sense it means the patient's renal function may improve. Whereas if you got a similar situation, renal failure post-cardiac arrest, but you didn't get concentration in the kidneys, that would tend to suggest it was not going to improve. So this is the same. It's sort of showing it's perfused and concentrating, but not being excreted. It's acute tubular necrosis. Now, I'll just ask you about this. No, I can't remember what I've got next slide, actually, but just looking at that, what do you think might be wrong with this person?
So I can see faint tracer uptake bilaterally, which appears fairly symmetrical, but it doesn't really change very much. And I think there's also in the pre and post void images, there's some urine left in the bladder. So could it be? I suppose I'd expect the kidney to take up more contrast. So is it chronic kidney disease, maybe secondary to obstruction, bladder outlet obstruction?
Basically, this is chronic kidney injury. It might be due to obstruction, chronic obstruction. It might be due to glomerulonephritis or some other condition. But basically, we've just got very poor uptake by the kidneys, and this is the kind of curve you get. There's the background. You might think that looks very good, but in actual fact, it's only just above the background. So it climbs only just above the background, and it falls very slowly. Remember, it's supposed to go down to half in 8 to 12 minutes. We're going down to half in 27 minutes. So this is the appearance you get of chronic kidney injury. And it could be a long-standing obstruction, or it might be some other cause. You really just can't tell. So small kidneys with flat curves. Okay, so still on kidneys, what kind of test is this?
The SMA scan.
Right, yeah, okay. So what might you use that for?
So I suppose it's used more for structural imaging rather than functional static images, and you can use it for things like cortical scarring.
Yes, cortical scarring is certainly one of the things you use it for, yes. As in reflux in children, you might use a DMSA and find cortical scarring. Obviously, anatomy as such, of course, is better shown by a CT or MRI, but for scarring, it's very good. So it binds the proximal tubule, so it's a little bit excreted, but not a lot. So basically, you're not going to see the ureters and the bladder and so on. And it's quite useful for telling the differential function. So if, say, a surgeon's thinking of removing a kidney, you might want to know whether that kidney has got, say, 50% of the function or only, in fact, 5%. If it's got 5%, it's not really worthwhile doing various nephrostomies and stenting and so on. It's better, if necessary, just to take it out. And if you have a mass, you have possibly a mass in the kidney and it takes up DMSA, you might find, in fact, it's functioning renal tissue. It might be a column of beta, for example. So this is an example, as you were saying, of the scarred kidneys, small scarred kidneys, and also this is the best way of looking for differential function. So right and left, in this case, the left one is only 39% and the right one is 61%. And this is a micturating cystogram, obviously not a nuclear medicine study, but very good way for looking for reflux, which is obviously associated with the scarring. So we get reflux and scarring. Now, one of the things about DMSA in both scarring and in this condition is that you can do a scan and it can show an abnormality. You can do a scan later on and it can in fact improve. So this is an example of somebody with pyelonephritis. Focal areas of damage, 6 months later, got better. Okay. Right. So I will actually ask you a question. So I'm trying to hurry on to ask you about this one. So what does this show? I've got that image and I've got that image.
So I can see tracer uptake in the right kidney, but I can't see any tracer uptake in the left kidney.
Right.
So I'll correlate with the ultrasound image to see if the kidney is present. And in the left kidney, it looks like it's cystic in nature with echogenic foci. So this can be a non-functioning kidney, and in this appearance, it could be something like multicystic dysplastic kidney.
Absolutely right, yes. That's fine. Okay. So this here is a renal failure after aortic aneurysm repair. Why? Well, it's basically because there is no uptake in the kidneys. There's no perfusion, there's no uptake in the kidneys at all. So that's not likely to improve. Now, this is a test we do occasionally. I would like to ask you about. It's not, but we don't do it that often, I suppose. What sense can you make of that?
Okay, so you have tracer in the left and right kidney, and at around 35 seconds, it decreases off. And you have a and at 20 seconds, it's also excreted. Is this some sort of excretory study?
Well, yes. You don't know what it's called? Probably not.
A micturating study of some kind?
Yes, it is. It's an indirect micturating cystogram, okay? So you haven't put a catheter into the patient. You've done your normal, say, MAG3. You've filled the bladder up, and then you've got the patient to micturate, and the bladder is emptied. And then you're taking counts over both kidneys, and they remain constant, as they should. So this is a normal, indirect micturating cystogram. But we've got this one. So these are the scintigram images of this one. And these are the renogram curves of this one. So what's happening here?
So as you, from left to right, there appears to be increasing tracer in the left kidney. So is this some sort of reflux into the left
Yeah,
while the patient micturates?
that's right. Yeah, so the activity in the bladder goes down, the activity in the kidney goes up, and here we have the activity in the bladder going down. But as the activity in the bladder goes down, the activity in the left kidney goes up. In other words, you've got reflux into the left kidney. The right kidney is more or less the same all the way along. You know, I think the way it's been drawn, if you notice, it's 26 at the bottom. This, in fact, is much more constant than it really looks, whereas you've just shown there's definite reflux on the left side. This was genuinely the same patient. So there was reflux on the left side. So do a DMSA scan, and the left kidney is relatively small and scarred. And now just moving on to the chest, which we won't do very much on the chest really. This is a ventilation perfusion scan. So as you may know, obviously you compare one with the other and look for defects. This is a normal study. If you're trying to tell ventilation from perfusion, in the ventilation you should have a bit of activity in the trachea, which is always quite helpful. And also the stats, the number of dots on the ventilation scan are in fact less than the perfusion scan. I think you can appreciate that there. Okay. Obviously, greater perfusion at the base is as normal. So that is a normal ventilation perfusion scan. That's showing where the trachea is. So this always has to go with a chest X-ray, of course. And that is, so ventilation, we've got activity in the trachea, and we've got perfusion that goes with it. And so what would this be?
Okay, so the top 6 images are ventilation and the bottom 6 are perfusion images.
Yeah.
And I think in the perfusion, in the left posterior oblique images, there appears to be areas of reduced tracer activity, which would be keeping with a perfusion defect. I'm trying to see if there's a corresponding ventilation defect, and I don't think I can see a ventilation defect in these areas.
No. So the conclusion is?
So there's a perfusion defect in this area. I'll correlate with the X-rays to see if there's any consolidative change.
Yes, I mean, you wouldn't normally do a VQ scan if you had an abnormality on a chest X-ray. You always have to have a chest X-ray first. It's really, if you've got an abnormality on the chest X-ray, CTPA would be much better, unless, of course, the patient's got flagrant allergy to contrast or is in terrible renal failure. But you know, if you've got something on chest X-ray, try and avoid a VQ scan. So basically, we've got not just one segmental defect, we've got more than one segmental defect. Because more than just one segmental defect would basically be a low probability scan. But when you've got more than one segmental defect, that makes it very likely to be a pulmonary embolism. Okay. And just to show this, which is just a feature you get sometimes, if you've given an injection of macroaggregated albumin for a perfusion scan, you've drawn a bit of blood back in the syringe just to make you sure you're in, and then you inject the patient, you get hot emboli like this. So it's a poor injection technique. So just moving on to the thyroid gland. So this is a normal nicotine petecnetate thyroid scan. You get uptake in the thyroid. You also get uptake in the salivary glands as well. If you've got an iodine uptake scan, you don't get uptake into the salivary glands, but petecnetate you do. And quite often you see a measure. it's important to bear in mind with nuclear medicine, you may get a little pen, radioactive pen, which is used to mark 6 centimetre distance, or you can also get, say, put a little, say, coin or some other cold marker, which in fact produce a cold area. And both hot and cold markers are used on nuclear medicine scans. So this is the difference really between the iodine and the pertechnetate. Both are quite good things to use. Pertechnetate, you give an IV injection, image them straight away. But it's trapped, not organified. It's not quite so good in that way. And the uptake is less on the pertechnetate scan than it is on an iodide scan. But with iodine, you have to give it the day before, and it's an oral administration. So it's not so convenient for the patient in that way. Now, I would like to ask somebody about this. So this is a 46-year-old female with an anterior neck swelling. What can you tell from this scan about this patient's neck swelling?
Okay, so in the anterior view, there's a photopenic area on the left-hand side.
Over here?
Yeah.
Yeah, okay. Is that the left-hand side or the right-hand side?
I'm not sure how to tell.
Well, the thyroid gland lies at the front of your neck, doesn't it? So the gamma camera will be in front of you for a thyroid scan. So for a thyroid scan, this would be the right side. Admittedly, it might say right and left and so on, but in actual fact, all thyroid scans, this would be the right side. Okay? Yeah, so photopenic area, so what's that likely to be?
So it could be a cold nodule?
Yeah, okay, good. And what someone has done is they've palpated the person's neck and found a lump, and they've put a marker there just to show that that is where the patient's lump is. So yes, it's a cold nodule. Okay. Now,
I think time for a break, please. And after the break, candidate 6 will be with us. Thank you, candidate 5.
choroid. So this one I would like to ask again about. This is a 42-year-old female with atrial fibrillation. Have I got a radiologist there? No.
Hello?
Hello.
Hello?
Can you see the slide?
Yes, I can. Is it a 42-year-old female with AF?
That's right. So what's wrong with them?
So there's a focal area of increased uptake in the left lobe of the thyroid. In a patient with AF, I'd be concerned that this was a focal hot nodule or a toxic nodule, giving them symptoms of hypothyroidism.
Okay, that's right. And why is there not very much uptake in the right side?
So could that one nodule be suppressing the rest of the gland, so there's not as much relative uptake in the rest of it?
Yes, that's quite right. So that's all. That's really what this is designed to show. And we've got the markers here showing it's basically a normal sized gland, 5 centimetres, but there's very little uptake except in this toxic nodule. Yeah, okay. I'm not sure this is okay. The hot nodule. And there is a nodule. Right. Now, this is somebody with a tremor, and would you like to say what this thyroid scan shows?
So this demonstrates sort of a diffuse uptake. I think it looks quite increased, more than I would expect it to be, but diffusely throughout the whole thyroid gland.
Yeah.
So I'm thinking it's more of a sort of both symmetrical, sort of whole diffuse process, something maybe like a Graves' disease or...
Yes, that's right. That's good. And what's this bit here?
I'm not sure.
No. Well, that's the pyramidal lobe.
Quite.
Quite often in Graves' disease, you get a pyramidal lobe taking up some pectinitate or iodine. And just to remind people again about the difference between a pectinitate and an iodine scan, you don't get any salivary gland uptake, pectinitate scan you do. So this is really another example of the same thing. Here we've got a marker saying SN sternal notch. That's again just showing where this is, basically. And quite often you have a quantification of the activity in both sides of the gland and also in the background areas, which will then be taken off from the main areas to give you a total sort of number of additional counts in those areas. So this, it says thyroid uptake is 7.4%. Now, if you're using pectinitate, I don't mean necessarily need to remember this, but the normal would be 0.5 to 4%, and this is 7.4%, so this is increased uptake. If it was an iodine scan, it should be between 10 and 30%. So that's another pyramidal lobe. Now, I will ask you about this one. This one, it says euthyroid lump in the neck. What is this lump?
So there looks like there's increased, sort of asymmetrical increased uptake in the right thyroid lobe. It doesn't look very diffuse, more sort of nodular.
Yes.
So whether this could be maybe a multinodular goiter or multinodular process?
That's right. So we've got a big gland. I mean, it's more than 5 centimetres top to bottom, and its patchy areas of increased and decreased uptake on both lobes, maybe a bit more on the right, but in both lobes, that's likely to be a multinodular goiter. Okay, and this person, now clearly you tell whether somebody is hyperthyroid or not from their thyroid function tests. But you may occasionally get somebody who is hyperthyroid from their thyroid function tests and yet have a scan like this, where there's no uptake at all. And this would be the case in somebody who maybe has had viral thyroiditis, de Quervain's thyroiditis. Or, of course, it could also be somebody who was taking thyroxine, as a Munchausen sort of situation. So that's a thyroiditis. And now amiodarone can affect the thyroid gland. You can get hypothyroidism. You can get hypothyroidism because the amiodarone contains iodine, and you get sort of a type 1 picture where you get increased uptake in the thyroid gland, or you can get destruction. It can produce a destructive reaction in the thyroid gland, and that's actually more common. And you get hypothyroidism because it's destroying the gland, releasing all the thyroid hormone. But in actual fact, if you do a radioisotope scan like this, you get virtually no uptake in the gland. So that's a type 2 destructive thyrotoxicosis caused by amiodarone. Now, clearly, as in most radiology, you don't get told things. You might be asked to do a radioisotope thyroid scan if somebody's had a thyroidectomy. But there are various causes of not being able to see the thyroid. Hypothyroidism, clearly, as we just saw, de Quervain's thyroiditis, an ectopic thyroid gland, if they're on anti-thyroid medications, or if they've had IV contrast. Actually, in fact, if you're doing a pateknotate scan rather than an iodine scan, you can normally get a reasonable image, even if the patient's been on anti-thyroid medication, or even if they've just had a CT scan containing IV contrast. Whereas with iodine, it's much more, very often don't get a proper image. And you can also get infiltration, of course. So there's a whole range of possible causes for not being able to see the thyroid gland. And this is a common sort of artifact, as it were. You may see this on a radioisotope thyroid scan. It's because the pateknotate has been secreted by the salivary glands and it's gone down the esophagus. And if you get the patient to take a drink, that will just disappear. Now, maybe I would like to ask you about this one. This is a 3-year-old with hypothyroidism. How could you explain their hypothyroidism?
So the area of increased uptake is a small sort of rounded area, and it's not in, if I'm judging this correctly, it's not in the typical expected location of the thyroid. It looks like it could be possibly a lingual thyroid.
Yes, that's right. So we've got an anterior view, the thyroid should be down here, there's nothing there. There's a little focus here, and on the lateral view, it's you can just about make out the soft tissue outlines. This is probably at the back of the tongue, lingual thyroid. And the patients are often hypothyroid because there's just not enough thyroid tissue in there to give them a normal thyroid function. Okay. Now, right, obviously chest X-ray, and I would like to ask some opinions on this. We've got a chest X-ray, and we've got this radioisotope thyroid scan here. So, would you like to say what the problem was here?
So, on the chest X-ray, there's an abnormality in the sort of superior mediastinal region where there's a large, there's widening of the mediastinum with a large sort of soft tissue mass displacing the trachea towards the, quite significantly towards the right. I can't see, I think it does extend above the clavicles, so is probably arising from the neck, and given that we're doing thyroid imaging, possibly a multinodular goiter or a significantly large goiter.
And what does this show you?
I think it demonstrates quite a large thyroid with no. I don't think there's any. I'm not sure if on that first image they're focal areas of increased uptake or they're markers.
They're markers.
They're markers, okay. So yeah, it's just sort of diffuse uptake throughout the thyroid with maybe one area of slightly increased uptake in the right lobe.
Yeah. So basically, what's happened is the patients had the chest X-ray you saw. They may well have had some other, say, ultrasound or CT imaging, and the thyroid seems to be, or people think there's something disappearing down into the chest. They may have done a CT and found an anterior mediastinal mass. And then the question is this anterior mediastinal mass, say, lymphoma or something, or is it a retrosternal thyroid? And here we have,
it's extending below the notch. So
Yeah.
this is retrosternal extension.
Yeah, so that's right. It's just showing that the tissue that's there is the thyroid rather than being anything else. There's a CT coronal image. Right, this is not a very good picture, but basically we've got a sternal notch marker and we've got activity descending below the sternal notch, so it's similar, maybe not such a good case. And we've got this here. What kind of image would you say this was?
This is a fused CT. Is it a SPECT?
That's right, yes. That's what I wanted you to say, and it's correct. It's a SPECT CT image. I didn't want you to say it was a PET CT image because it isn't. And it's just to show that they've put the CT image with a SPECT image together, SPECT being just, computed tomography of your radioisotope scan, and this demonstrates that the lump seen on the CT is in fact taking up the pertechnetate. There's a retrosternal thyroid. Okay, now, Now here we've got a Sestamibi image, an iodine image, and a third image.
Mm-hmm.
And this person has hyperparathyroidism. Can you explain what you've got in front of you?
So I don't know the exact phases, but I think I can see that there is uptake of the radioisotope in the thyroid gland and the salivary glands, which I think is normal. But on what I think is the delayed image, image C, there's a small area of persistent uptake in the region of the left lower thyroid, which could be an sort of an abnormal parathyroid.
Yeah, I mean, I haven't really explained this, so I'll explain it now. It is an enlarged parathyroid, that's true. But the thing is that this is Sestamibi, which is taken up by the thyroid gland and the parathyroid glands. Then in the middle we've got I123, which is taken up just by the thyroid. And then you take B away from A and you get C. It just demonstrates, more easily the fact that you've got an area here of uptake that isn't thyroid, that in fact is parathyroid. So that's quite often used in nuclear medicine. You use different radiopharmaceuticals and you take one image away from another to show something. So that is an area of a parathyroid adenoma. Now, we in fact don't use iodine. We use Sestamibi, we use Protecnotate, and we do a subtracted image, but it's just the same thing, really. So this is maybe not such a nice set of images, but it's a homegrown image, really. So it's a thyroid image, which is Protecnotate. It's a SESTI-MIBI image, and they've taken A away from B, and you have an area there where there's uptake due to a parathyroid adenoma. And you also do a wider sort of chest image in a SESTI-MIBI scan, just because occasionally you can have an ectopic parathyroid adenoma. And just to point out, the SESTI-MIBI image, SESTI-MIBI, as you probably know, is also used for cardiac nuclear medicine. It's taken up by the heart. That's a subtraction scan. Now, sometimes if a patient has been on thyroxine or say antithyroid medications, they're not really suitable for a subtraction scan. And then you do a SESTI-MIBI washout scan. You do a SESTI-MIBI image at 15 minutes, and you do a SESTI-MIBI image using the same radiopharmaceutical at 2 hours. And the theory, anyway, is that the SESTI-MIBI gets washed out of the thyroid but remains in the parathyroid. It doesn't always work, but it's not quite as good as the subtraction scan, but it's what's needed if the patient has been on antithyroid medications or if they're on thyroxine. So it's a washout scan, again, for parathyroid adenoma. That's again another thyroid, Protecnotate, SESTI-MIBI, take one away from the other, and you get the site of the parathyroid adenoma. And we have here got it on the SPECT CT images where the parathyroid adenoma is. And the idea of this is it makes it easier for the surgeons. At least in theory, they then don't have to explore both sides of the neck, and they can hone in much better for where the parathyroid gland is. And this is an image, I must admit, from Google. It just shows that there's an ectopic parathyroid adenoma on this SESTI-MIBI image, and SESTI-MIBI has gone to the heart. Now, I won't ask you about this one. I'll ask you in a minute. But this I was asked to put in, but really it's hardly done at all in nuclear medicine anymore. But I think for some reason somebody got asked about it. But anyway, it's a sulfur colloid scan. So this goes to the liver and the spleen. And you can see here people have put little lucences, maybe little radiopaque markers along the side of the patient's ribs to show where the bottom of the liver was. So to give you some idea of the size. This had its heyday years ago before CT was widespread. And it was a way of looking for focal defects in the liver. But one thing you can find this is a particularly distinctive picture with cirrhosis, where the liver shrinks, and it shrinks away from the ribs. You get ascites in between. The spleen gets large. You get what's always called left shift. You get increased uptake in the bone marrow as a feature of their cirrhosis. So it's cirrhosis with ascites and leftward shift to the bone marrow. Right, so it's colloid shift to the spleen and bone marrow, and you may get patchy uptake within the liver and a large spleen. You can use it for focal lesions. It's not really done these days, but one thing, it does contain Kupffer cells. Therefore, if you have focal nodular hyperplasia, it would take up the sulfur colloid where you've had a hepatic adenoma. It wouldn't take it up. Now, I would like to ask about this one, which is much more commonly done. So I've got two sets of images. Could you tell me what scan this is and what it shows?
So this was a HIDA scan.
Right.
It shows excretion of the isotope through the biliary tree.
Right.
This one demonstrates that there is, on the first image after 5 minutes, there's tracer uptake in the liver, which gets progressively less, and then there's tracer in the biliary tree, and then on the most delayed images, it's mostly within the gallbladder itself. While the gallbladder.
That's right, and these are the later images, which just show it's gone through to the small bowel. So that's a normal HIDA scan. Normal HIDA scan, there we are. Okay. Now, what about this person with abdominal pain? Why might they have abdominal pain?
I think on the second and third image, there's tracer in the intrahepatic and common ducts, which is, I think, maybe not passing through as...
What haven't we got a picture of?
The gallbladder?
Yeah. Now, assuming the patient hasn't had a cholecystectomy, which of course is sometimes a big assumption in the hospital, isn't it?
Mm.
But why have they got abdominal pain?
They've had some other form of sort of abdominal surgery, maybe a resection, and everything's plumbed in abnormally.
No, the answer really is because there's a stone in the cystic duct, so the HIDA can't get through to the gallbladder. That is a way, I think in some countries it's used quite commonly for the diagnosis of cholecystitis, so here we tend to use ultrasound or sometimes CT maybe, but yeah, this is a feature of cholecystitis. The radioisotope will not go through to the gallbladder. And you can also get this, which is a rim sign. Because the gallbladder is distended and pushing against the liver parenchyma becomes denser. It's got more radiopharmaceutical, it's squashed together. That's also a feature of cholecystitis. So, reasons for not seeing the gallbladder, well, you had the gallbladder out, you've got cholecystitis. In chronic cholecystitis, the gallbladder may get radiopharmaceutical, but only after about 4 hours. Obviously, if the liver's not working, or there's biliary obstruction, it won't go through. And unfortunately, also both inadequate fasting, because the gallbladder is contracted, or excessive fasting. If the patient hasn't eaten for 24 hours or something, the gallbladder is greatly distended, then the HIDA might not be able to get in. But those are causes of non-visualization of the gallbladder. And this is another, it's also a HIDA scan, and this is somebody who's had an operation, and they are presenting with abdominal pain. What might be the cause of their abdominal pain?
They have a biliary leak.
Yes, that's right. So it's leaking down in the paracolic gutter. That's another feature of a HIDA scan, another use of a HIDA scan. So, I must say, what we seem to be asked to do HIDA scans for is biliary dyskinesia. Basically, the gallbladder, you can do a gallbladder ejection fraction after giving them Calogen or something like that. It should be greater than 35%. But in fact, HIDA scans are very good for these other features as well. Choledochal cysts to identify them, or in the neonates to distinguish between biliary atresia when you obviously won't get anything going through into the bile ducts, and neonatal hepatitis when you should get some. And this is just to say on a HIDA scan, you can also get some renal excretion. If there's some reason for the radiopharmaceutical not being able to get by biliary route, it must get out some way. It will go out through the renal system. Right, so this is a different topic. We can say that this child has had some rectal bleeding, and would anybody know what this scan was? Well, sorry, would you know what this scan was?
It's a Meckel scan.
Yes, actually, it says Meckel scan at the bottom.
Definitely.
So here we have given a patient petatate, excuse me, it's gone to the stomach because it gets taken up by gastric mucosa, and it's gone through the renal system to the bladder, but it hasn't gone into anything in between. There's no uptake in the gastric mucosa containing Meckel's diverticulum, so that is a normal Meckel scan. But what about, you see here, what's this person got wrong with them?
So they've got an area of increased uptake on the sort of images after 10 minutes and persistently through to 30 minutes outside of the stomach.
Yeah.
I'm suspicious of ectopic gastric mucosa somewhere along the bowel.
So it will only show up a Meckel's diverticulum if they've got ectopic gastric mucosa in them. But I think this is often the cause of bleeding, of pain, of intersection volvulus. So, a lot of the Meckel's diverticulum, where it's important to detect it, a Meckel scan will detect it. Right, now, again, a different topic. This is just to show you a normal octreotide scan. Now, an octreotide scan has this rather peculiar appearance. It gets picked up by the spleen, the liver, and the kidneys, and not much else really, at least not very much else. It has a sort of distinctive pattern. Now, this is, it might be quite difficult, but I'll ask somebody about this. So this is a 57-year-old with diarrhea and blushing. So could you tell me what might be wrong with this patient?
So I think there's an area of quite increased uptake in the right upper quadrant, sort of overlapping where the liver is, but it's more focal than in the rest of the liver.
Yeah.
That history of diarrhea and blushing can make you think of maybe a carcinoid tumour.
Yeah. So that's why we've done this octreotide scan. Is there any evidence of it?
I think there's a small area of uptake just below sort of the lower pole of the right kidney. I don't know if that's an artefact or...
No, that was thought to be a carcinoid tumour. And as I understand things, if you've got symptoms, you're likely to have got metastases from it. And there was hepatic metastases. Well, this is the same thing, so I should have shown you this really. It's blown up, it's enlarged, and as you correctly identified, there's a carcinoid tumour, and there's some abnormal areas in the liver. And this is obviously a CT scan, it's a SPECT CT, and the SPECT images showing the increased uptake in the liver.
Andrew, thank you, candidate 6. We will go back to candidate 1 now.
Okay, thank you.
Okay, thank you.
Candidate 1, if you can raise your hand, please.
Right, we're just looking at this. This is an indium labeled octiotype scan, and I'll have to, yes, okay. So if you've got this scan here, and I've got a partner CT scan here.
Yeah, so there is a mesenteric soft tissue mass with a arterially enhancing liver lesion, and which is showing uptake within the octiotype scan as well. So again, findings would be of a carcinoid with hepatic metastases.
All right, just I didn't really show you this very long. Just look at this. Does that fit with what you were saying?
So the liver metastases, yes, and there is this sort of a soft tissue mass in the just at the portal confluence above the again in the mesenteric region, not really in the mesentery actually, but there is a soft tissue region in the central abdomen. Yeah, just all of that soft tissue there. Yeah.
So what else is a carcinoid? What else is an octiotype scan used for?
Octiotype, apart from carcinoid, any neuroendocrine tumor. This could be a pancreatic neuroendocrine tumor just at the head, which is arterially enhancing.
Yeah, so this is a pancreatic tumor rather than a carcinoid. It's in the pancreas. Yeah. And that's what it turned out to be. It was a gastrinoma with hepatic metastases. And there it is identified in the pancreas and with hepatic metastases. Yeah. Okay. Right. So what about this case? We've got this chest X-ray. And this is actually a PET scan, even though I'm not supposed to be doing any PET scans.
Okay, so the chest X-ray demonstrates a normal soft tissue mass in the right lower zones. It doesn't obscure the hard border, so likely within the lung parenchyma itself. It is quite well defined. However, I don't really see any other contralateral lung lesions, but it would be suspicious of a lung lesion. On the PET scan, it is actually demonstrates moderate FDG uptake, not as much as the adjacent heart, but there is mild to moderate FDG uptake on the right lesion.
Yeah, okay. Any ideas what it might be?
It doesn't look like a lung malignancy, because I would expect that to be highly FDG avid. And it is quite well defined. Could it, just having second thoughts, could it be, I'm not sure actually, could it be a carcinoid? No, but that's too big for it to be a carcinoid in the lung.
Okay. So what lung malignancies don't show uptake on a PET scan? Classically.
Would it be squamous? I'm not sure. I'll be honest. I'm not sure.
Well, carcinoids often don't. And the other thing, which is very common lung cancer, is an adenocarcinoma. That often doesn't either on a PET scan. But yes, it's very well defined, and we're in the carcinoid section of this talk, aren't we? So not surprisingly. Now, so what does this show?
So this is an octiotype scan which shows actually avid uptake within that lesion. So that would be in keeping with the carcinoid of the lung.
Yeah, so it's not taking up much FDG, but it's taking up quite a lot of octiotype, and it was a carcinoid. So octiotype scans get uptake in all sorts of things. Yeah, so carcinoid pituitary tumours, pancreatic exocrines we just saw. No, pancreatic endocrine, sorry, not exocrine, endocrines we just saw, but only 50% of insulinomas, phiomas, neuroblastomas, carcinoma, medullary carcinoma of the thyroid. Again, a change of subject. This is a MIBG scan. It's a normal MIBG scan, just showing the areas that take up the MIBG. Okay. So this here is an abnormal MIBG scan. So the patient might have, for example, hypertension, and whereas you wouldn't normally, you find it very difficult to see an adrenal gland on a normal patient. You've got an uptake in an adrenal there, which is a pheochromocytoma. This is not really used to diagnose pheochromocytomas, but more to find them once they've been shown to have a raised adrenaline or noradrenaline. Right, now I would like to ask you about this. What does this show?
So again, this shows some abnormal uptake on the right upper abdomen.
Yeah.
In an infant, I would be worried about a neuroblastoma, which would show an MIBG uptake.
And that's what this was. And just to point out the obvious point, because somebody a while ago asked me, was this really a child? I mean, you can see it is a child, just the simple size. You know, there is some relationship between the size on nuclear medicine image and the size of the real object. So it's a child and it's a neuroblastoma. And what about this person? What's this person got?
So again, this is an MIBG scan, anterior and posterior. So there is uptake in multifocal regions within the abdomen, in the upper and sort of mid-abdomen on the right side. There's also a focus of uptake up in the neck on the left side. So this could represent a Men's syndrome with a pheo and also a parathyroid lesion.
It could do, but I mean, in the circumstances of we're talking about, pheos are not always benign. There is a certain percentage of them. Somebody else might be able to tell me how many, but it's a minority, but it's still a definite number that are malignant.
Sure.
And it was a malignant one. It's a malignant pheo. So those are the things that MIBG is taken up in. Quite an overlap with the octreotide things, but this would be more often used for pheos than would an octreotide. Now, gallium scan, these are only just to mention them in passing, really. Gallium is taken up by infections and by malignancy. It used to be very commonly done, but it's really quite rarely done now because it's quite non-specific. That's a typical picture of a gallium scan. It can be used for sarcoidosis of an lymphoma, but it's and it will show up as positive in PCP, pneumonia, for example. But it's other than really to know that it's something taken up by both many malignancies and by many infections. I don't think you really need to know much about that. Now, indium scans. White cell scan, you can use either indium or technetium. It's a matter of actually labelling the white cells. You need to take white cells off. You need a radiopharmacy on site to then re-inject the labelled white cells. Okay, so it's imaging at 4 hours, imaging at 24 hours. It's in the longer term isotopes. Now, taking this as an example, this person's had surgery and they've had an indium scan. So what might this indicate?
So there is increased uptake in a linear fashion centrally at the region of the aorta, and also see some uptake within the upper sort of abdomen and chest as well. in a patient with recent aortic surgery, this might suggest an aortitis or infection around the surgical site, and I would review and correlate with some cross-section imaging to identify this.
Yeah, you must have the cross-section imaging, which there it is. The patient actually had a graft and there was an infection around with a little bit of gas in, as you can see. It can also be used for inflammatory bowel disease, abdominal pain. Here you see we've got it involving a large part of the large bowel, ulcerative colitis. You've also got technetium-labelled HMPAO white cell scans, which give you much better resolution, and it's much better suited to the gamma camera. Very good for many parts of the body, but not so good for the abdomen, because the HMPO is excreted in both the renal and the biliary system. So after about an hour or 2 hours, the images of the abdomen are full of radioisotope anyway, so it will only do for other parts of the body or very early on for the abdomen. So this is a relatively early image, and you can see you've got uptake in what turned out to be terminal ileum. I think that's what it was. That was Crohn's disease.
Andrew, we have to go to candidate 2 now, please.
Okay.
And candidate 2 will remain with us till the end. So
Right.
Thank you, candidate 1.
Thank you.
Right. So, as in any test, there are false negatives and false positives. Viral, parasitic, or fungal infections will often not show up on a white cell scan. Osteomyelitis or low-grade infections won't show up either. And obviously, if given steroids or some kind of immunosuppressives, if the patient's hyperglycemic, then it won't show up on a white cell scan either. And false positives, without going through in too much detail, basically anywhere where white cells will go, like, for example, if you've got a stoma, if you've got a line going in you somewhere, it doesn't have to be infected, it will take up the white cells. So all these things will take out the white cells, but not really what you're looking for. So various tumours, hematomas. Yeah. So it's just anywhere where white cells will go will show up on a white cell scan, basically. I won't worry too much about this, just to say that technetium you image more quickly, but it's not so good for the abdomen. Indium is quite commonly done, and gallium is very non-specific, so it's not so often done these days. Now, I would like to ask somebody about this. You've got a patient who's got anemia and PR bleeding, and what kind of a test is this?
I'm wondering whether this is a red blood. Is this a red cell labeled scan?
It is.
And there is uptake in the aorta, but then also high uptake in the bowel that I can see. So I'm concerned that there's the abdomen appears to be the abdominal aorta appears to be aneurysmal, and I'm wondering whether there's an aorto-enteric fistula that's causing bleeding.
Well, I suppose there could be. I don't think there was. I think the fact the aorta is aneurysmal is sort of incidental, really. Why might you normally do this kind of scan?
You're trying to locate an area of bleeding.
Mm-hmm. Would it be your first line, do you think?
No.
What would be your first line?
So if it was a first line would be a triple phase CT in the acute setting.
Mm-hmm. So why might you do this?
When a bleed isn't sufficiently brisk enough to identify with contrast extravasation?
Yes, I think that's right, because this shows up when there's 0.2 mils per minute, whereas CT you need 0.3 mils per minute of bleeding. On an angiogram, you need 0.5 mils per minute. So yes, it's more sensitive. And the other thing is that to show up on a CT, really you need the patient to be bleeding at the time. And the CT might show, say, a tumour, for example, and therefore you might say, well, they've found a tumour, therefore that's what's likely to be bleeding. But as regards actually finding the bleeding site, the patient needs to be bleeding when you do your CT scan. Otherwise, you don't see it. Same thing with angiogram. The patient needs to be bleeding when you do your angiogram. So if you've got you might do that first, but if you've got somebody who's bleeding and they're bleeding every now and again, you can't work out what's going on, this might be a good test to do because you can at least hone in on where the bleeding might be. And because you can scan the patient, you inject the patient, you can scan them. You can scan them again 2 hours later, or half an hour later, or an hour later. You don't need to re-inject them, you can just scan them again. You see? So in that kind of situation where you have intermittent bleeding, it's quite a good test to do. Having found the sort of basic area of bleeding, you then really have to then go and do either some other test or focused on that area. Okay? And obviously, if you want to treat it, you might need to embolize it, and you then need to do an angiogram. But because you can't keep on doing a CT scan several times, so you might do this. Right, so that is a labelled red cell scan. We're very nearly finished, which I'm sure people are pleased about. Just to show this is a DAT scan. We get asked to do quite a lot of these. This is a normal DAT scan. You have these little commas. A normal one always looks like that. It's blown up. So, what might this patient have got?
Probably Parkinson's, because you've no longer got the normal common configuration. You've got dots.
That's right.
Basal ganglia. So there's a kind of problem with regards to the, I think it's the dopaminergic system within the basal ganglia. So they're most likely going to have a Parkinsonian present symptom.
They might be Parkinson's, they might be one of those Parkinson's plus things, or of course it could be Lewy body dementia as well. Obviously you have to put it in the clinical context. But it's a very good test actually, in that people with, say, vascular Parkinson's or drug-induced Parkinson's or just essential tremor, well, the great majority of them want to have a scan like that. And the great majority of people with Parkinson's will have a scan like that. So it's quite good in distinguishing. You get a few people who are in between, but that's quite a good test. So there we have just what I've said. And that's really me finished. I just wanted to say that these two books are very good. And if you want to read some basic nuclear medicine, I'd recommend either of these two books. Thank you very much. And I think there should be a feedback somewhere. So probably if I go on, I might get a feedback or... Yes, there we are. So you can hopefully do your feedback. You can say whatever you like. Thank you very much.
Thank you very much for your time.